Weatherson. My pronouns are she, her. I'm a white woman with gray and brown hair and glasses, and I lead the staff uh, for the Medicaid Advisory Committee, or the MAC. And this is the MAC's public meeting for April 2025 to help fulfill our federal and state mandate to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on how to run Oregon's Medicaid program. I'm going to share a few logistical announcements before we get started. We'll ask folks to mute yourself if you're not speaking. And for folks who are joining by phone, please mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you have to leave, please hang up and rejoin the meeting. And MAC members, please use the raise hand button if you have a comment or a question, or you can put a note in the chat. The Medicaid Advisory Committee has built in time for discussion after each presentation. I will say our agenda is pretty tight today, so we'll see how much we get to. But in any case, MAC members will speak first. And when we've exhausted questions from MAC members, if there's any remaining time for the agenda item, we can take general questions. And we have left about 25 minutes today for public comment near the end of the meeting. We do have ASL interpreters. I'm not sure our Spanish interpreters have arrived. You can pin the ASL interpreters video by clicking on the More button next to their name. And there's also a button for interpretation, which is where you'd find our Spanish interpreters if they have arrived. So with that, I am going to hand off to the MAC co-chair, Dr. Caroline Barrett, to take us through our meeting.
Good morning. Welcome, committee members and members of the public. Let's start with roll call. David Lima.
Here, thank you.
Emma Sando.
I'm here.
Heather Jeffress.
Here.
Hillary Thompson. Jerry Weeks.
Here.
Kaya Adams. Kelly DeVore.
Here.
Lisa Pearson.
Here.
Welcome back, Lisa. Ronnie St. John. Shannon Buck. Stacy Shaw.
Present.
Dr. Tony German.
Morning here.
Peter Starkey. I'll circle back. Are Hillary, Kaya, Ronnie, Shannon, or Peter here? Do we have a quorum, Sarah?
We do have quorum.
Wonderful. Committee members, last week you received draft minutes from our most recent regular meeting to review. Please take a moment to review the minutes for any errors or omissions. Do any committee members have concerns about the minutes? If there are no further revisions, I want to also call attention to the consent agenda, which you also received prior to this meeting for review. Do I have a motion to approve the February meeting minutes and to acknowledge our consent agenda?
I will move to accept the minutes and acknowledge the consent agenda. This is Heather Jeffress.
Thank you, Heather. Do I have a second?
Second, it's Jerry Weeks.
Any objections? Any abstentions? The motion carries. So now we'll move on to our Medicaid director update. So Director Sando, I'll pass it off to you.
Great. Thank you so much. Hi there, Emma Sando, she, her pronouns. I am super excited to be here with you all today. So much has been going on in the Medicaid program over the last couple months, and as well as OHA. So I'm here to provide a brief update of some of the more major things that have been occurring. As you all know, we are working very, very hard to make sure that you all have access to the latest information about what is happening at the federal level. And as such, I would encourage everyone to continue to check the federal response page that OHA has set up. On there, we have a drop down for Medicaid where we're posting some of the most recent information that will have a lot of answers to questions that you may have about Medicaid. But again, if there's anything that comes up, you're always uh, uh, more than encouraged to reach out to myself or Sarah or any of the other OHA teams to ask any particular questions, and we'll work to get you an answer. One of the things on that page is related to a recent set of guidance that CMS, our Centers for Medicare and Medicaid Services federal partners, put out related to the announcements around 1115 waivers. So that announcement essentially said that the way in which some of the 1115 waivers, including Oregon's current 1115 waiver, is financed. They will not be renewing that financing mechanism going forward. So it's a process that's known as DSHB, and I just forgot what the acronym stands for, so I'll get that in the chat at a later point. But the program was approved under the Obama administration, not approved under the Trump administration, first Trump administration, and then again the Biden administration started the DSHB program for 1115 waivers again, and now the Trump administration that says that they're not moving forward that DSHB funding. All of which to say, it does not impact our current designated state health program. Thank you for whoever put that in the chat, Sarah. It does not impact our current waiver and our current approval. So it specifically said that current approvals can continue to move forward as they have been, and so as such, there's no changes to the current approval that we have with our federal partners. A better phrased set of information is on our website if you want to pull that down to share with any partners that may have questions about the 1115. But again, similar to earlier guidance that our federal partners put out about about the way in which they're treating 1115s, there's no changes to our current 1115 as of this new guidance. So our current 1115 remains in place as it currently is written as of now. The federal government and Congress is working on a budget, a revised budget that has specifics related to the Medicaid program. My understanding is that we'll be able to see a draft wording and draft legislation over the next couple days. So at our next meeting, I should have more information about what Congress is thinking around the ways in which they're planning on or they are thinking about changes to the Medicaid program, if any. So moving from Congress to the state legislature, about a month ago or so, there was a hearing related to the contract length and which impacts our procurement timing. We Director Sejal Hathi put forward testimony, and myself and Dave Baden testified in person, um, e- essentially saying that there was an amendment that instead of having to have a statute change every time the contract needed to be extended or amended, that authority would be with OHA. So if knock on wood, a pandemic were to happen and it just wasn't the right time for a procurement, that authority would be a decision of OHA, rather than necessarily going. The legislature may not be in session, or whatever it may be, that would make it more time intensive to get legislation changing that. And if that amendment were to be passed, that OHA could or was planning on extending out the current procurement an additional 2 years, so that the new contracts would start in January 1, 2029 rather than January 1, 2027. We have been ready to go with a procurement. We've been doing a lot of public input, public comment process, and have been working diligently, and are able to do that procurement if necessary. But we are watching the legislative session very closely to see whether that amendment were to pass or not. And then finally, I do want to touch on some sort of shifting back to the national scene, but sort of outside of the scope of the Medicaid program. There was a number of grants that were canceled by the federal government in March. They are specific to grants funded by the CDC, and and SAMHSA, the Substance Abuse and Mental Health Administration. And it was approximately 117 million in COVID era grants that funded a variety of different OHA programs. So this would impact on many different parts of Oregon, including the 9 federally recognized tribal communities. But in April, beginning of April, a district judge in Rhode Island temporarily restored the $11 billion in these grants across the country, and due in part to a court order that was, or due to a court order, but due in part to Oregon's participation along with 22 other states. This is a temporary order, and there are many unknowns at this time. And we are working with our partners in SAMHSA, or sorry, in behavioral health and public health closely around those impacts. This predominantly impacts programs outside of the Medicaid program, but we are working closely to be in alignment with them on any changes in any policies that come about. But I would continue to check our federal website, which I can. Oh, Sarah. Of course, Sarah already put the link in the chat, so you can see the link in the chat for the federal website. So as things develop in that space, we'll continue to update that with additional information.
Hello, this is Kaya from Cascade Health Alliance, and I'm on the Mac. I was just wondering, I just stepped away for a second, and this is in regards to the 9 tribes of Oregon. Is that what you're talking about?
This is the public health COVID-19 grants that went to the public health division and the behavioral health division, and they impacted a variety of different public health activities, as well as those funds funded a number of public health activities in the 9 federally recognized tribes in our state.
Okay, and the link is in there. I'm also a tribal member and I work at CHA. And so I've been going head to head with our tribe, our tribal clinic for the past few months. It's just been real messy.
Yeah. And I think there are a lot of additional detail on our website around that as
All right,
well.
thank you.
Well, thank you so much, Emma, for being here and giving us those updates, and Sarah for dropping those links in the chat. In the effort to keep us on time with our packed agenda, we will move on. So Sarah is going to give us our Advancing Consumer Experience ACE Subcommittee update.
Great. Oops. Let's see if I can. There I am. All right. So the subcommittee has been kind of shifting to focus on how that subcommittee will turn into the new Beneficiary Advisory Council, which, as we've talked about in the past, is going to be a new federally mandated group that will work alongside the Medicaid Advisory Committee and share membership with the Medicaid Advisory Committee and bring more consumer voice to the policy recommendations that we make. And so in that effort, the state of Oregon was very fortunate to not just fortunate, we worked really hard to get this, to be one of 7 states that is receiving technical assistance and pass-through grant funds to help us develop what our new Beneficiary Advisory Council is going to look like. And we are working with Willamette Valley WVP Health Authority. It stands for Willamette Valley Physicians. But the interesting piece about this group is that they have a peer program. And so they are really out in their community with peers, working with consumers. And they are helping lead both our existing subcommittee members and members of their in their network who are on OHP through a process of talking about what kinds of things they would need to be successful members of any kind of group that's advising the agency. And so we had the first of 4 meetings to talk about these things. And the first meeting, we had about 18 consumers, including 7 of our 8 subcommittee members attending, and they were all very engaged in the conversation. The WVP Health Authority opened with meeting agreements. They provided some background about the MAC and the BAC, and then led the group through a discussion based on 8 questions about decisions we would need to make in order to produce bylaws for the Beneficiary Advisory Council by the July 9 deadline to publish those bylaws. And so we heard a lot of wide-ranging views, but I would say the group reached consensus on a few questions, including making terms for members 3 to 4 years, keeping the application process really simple, offering compensation and reimbursement, and offering examples of changes and outcomes the committee can affect to attract potential members, not having the members be appointed by the governor, and having monthly meetings. They find those not burdensome, but they could be better if they were not in the middle of the day. And they believe the membership of this council should be around 10 to 12 people and reflect Medicaid demographics. And so again, there'll be 3 additional sessions. The next one will go through some questions, and then there'll be 2 follow-up sessions that will be more of a free ranging discussion about the kinds of things folks envision in a group like this. So in addition to those sessions with the WVP Health Authority, the subcommittee is planning to meet on May 23rd. And that is what the subcommittee's been up to. Any questions?
Nope.
Great.
Committee members, any questions? Members of the public, any questions? Okay, well then, we are a few minutes ahead of schedule for our next topic is the public health emergency unwinding closeout update. Sean, are you here already?
Yes, I am.
Awesome. Would you mind getting started a little early?
That's not a problem at all. My name's
Great. So
Sean
we
McNulty.
have, oh, go ahead. I'll let you introduce yourself then. Thank you.
My name's Sean McNulty. I'm OHP's member communications coordinator. Here to talk about some demographic findings and results from the pandemic health emergency unwinding. Since that process wrapped up at the end of February, we wanted to provide those results and see where we can, both what we did well and where we can learn from in that process. We can go to the next slide. So just some background. The pandemic itself kicked off just about 5 years ago. It was in March 2020. We saw that enrollment grew from that time, from 1.1 to nearly 1.5 million people. And then back in April of 2023, we began the process of going through all of the members on OHP and seeing if they're still eligible to continue benefits after the pandemic rules expired. And we needed to figure out whether or not they were still eligible again. Back during the pandemic, we still did some renewals to keep information fresh, but weren't actually removing people from benefits when they no longer qualified and needed to go through the process of figuring that out after the pandemic was over. So the headline, I guess, is that we achieved either the first or second highest Medicaid renewal rate in the nation, with about 83% of people retaining benefits of some form. That is starkly different from some other states where we saw more than half of members keep losing benefits. So Oregon's experience has been drastically different on that, which is something to celebrate there. There are 2 studies that measured this, Georgetown and KFF, former Kaiser Family Foundation. They both did studies on this. I think the difference on whether or not we're first or seconds depends on how you treat North Carolina, which expanded their Medicaid program during the pandemic unwinding, so had drastically different rules coming out of it than they did going in. We also largely did pretty well on demographic equity in this process. There are some groups that were slightly underperforming in terms of they had slightly disproportionate closures or response rates, but we see some quite consistent across the board, as we'll get into in the next slide. And for a lot of priority groups, we saw higher renewal rates showing the efforts were effective. So on the top line summary here, we have 83% of people keeping benefits of some form, but only 80.3% are keeping the same benefits. That means OHP to OHP keeping the same thing. There's about 2.8% of people who kept medical benefits of some form, but had a reduction. That's usually going from OHP full benefits to a Medicare savings program only, where they're getting some help paying their Medicare costs, but not the full OHP coverage with dental, transportation, and all of that. Then about 16.9% of people had their benefits closed entirely. Our rough categories there. Out of the people that were closed, not all of them are going to qualify for the marketplace, but the ones who are potentially eligible, they're not on Medicare, they don't have employer coverage on file, things like that, are going to get referred over to the marketplace, and 130,000 of them were sent there. We don't have that matched up to individual member data to know how many of them actually ended up enrolling in the marketplace, though. They may have other reasons they were ineligible and things like that. If we can keep on going to the next slide. Some of the reasons we're so high on the renewal rate, we want to highlight. First off was our sequencing of renewals. We intentionally structured the renewal process to make sure that we have the members who we wanted to provide the most support, for instance, members who speak other languages, spread out evenly through the process. Other members that we wanted to keep coverage later on into the process. For instance, people who are potentially eligible for OHP Bridge, we delayed even further. And then the people who are more likely to keep benefits without much action needed, we put earlier in the process. And that helped structure our workload to make sure members who speak a second language are consistently able to get help in their language and things like that. So we didn't overwhelm all of our Russian speaking staff with all the Russian speakers in a single month, think of something like that. We also really heavily automated renewals whenever possible to minimize needing a response from a member where they could potentially not respond and lose benefits for that reason alone. The system, whenever it starts a renewal, tries to compare the information we have on file to federal data sources. If it's able to verify at that step, we don't even need to request a response from the member, and that was the majority of experiences during the process. So being able to heavily use that minimizes potential losses of coverage due to non-response. Oregon also extended the timelines for response longer than any other state. We had 3 months of renewal process as well as 2 months of advance notice before termination. So we ended up giving people more time to respond, and that also has an effect on renewal rates too. Creating OHP Bridge also increased our renewal rate as well. We were able to cover 34,000 more people as of March 2025. People who were during the pandemic unwinding process their renewals indicated they would be eligible for OHP Bridge when it launched. We're able to keep their benefits longer until OHP Bridge began in July of 2024. We also have our pretty robust outreach efforts, particularly the Community Partner Outreach Program and their OHP assisters. They've got 16 to 1,700 assisters across the state that help people renew their benefits directly and whatnot. So working closely with them and making sure we're doing outreach and reaching all the different communities in Oregon is a really important part of this success as well. Then it doesn't directly affect renewal rates, but I did also want to mention continuous eligibility rules we put in after people go through their pandemic renewal. They were keeping benefits for 2 years, with some exceptions, such as if they move out of state. But in general, they'll keep their benefits for that 2-year period. Even if they no longer qualify due to income or whatnot, they'd be approved for that set duration of time. That really focuses in our remaining staff on the renewals that were going through the process at the time. So we don't have attrition in between renewals. Before OHP Bridge and continuous eligibility, about 30% of our members who lost OHP would return to OHP within a year. So not having to process those additional cases as well helps focus our efforts in on the remaining renewals to support them. If we can move on to the next slide, we'll get into some demographics. So this slide here shows our race and ethnicity renewal rate outcomes. The baseline in this chart is 83% here. So groups that are slightly below that include Asian, Native Hawaiian, Pacific Islander, Middle Eastern, and North African, and other on this category. But we're seeing pretty similar renewal rates across most of these groups, and that's something to celebrate there. We also did particularly well in ethnicity and written language, where we had very few speakers of second languages that were underperforming there. If we go to the next slide, I think we have a list of those. So the full list of ethnicity groups that had slightly disproportionate closure rates is on the screen on the top half. For the written languages, we really only had Ukrainian, Chuukese, Swahili, and English itself below the average. So that's something we really did well on the support for members who are speaking other languages there. We do see a little bit of a pattern of Asian and Pacific Islander communities seeming to underperform. So that seems like an area where we can expand our outreach in the future. But looking at these weaknesses is where we keep ourselves performing so well and doing things equitably across to reach all of our community groups across the state. If we can keep moving on. We also looked at our outcomes by age. We saw children had the highest rate of continued benefits, which makes some sense given the higher income limits for children. The younger adult demographic seems to have the highest closure rates. And then we also wanted to note that the 65 and up age group had the highest level of the benefit reductions I mentioned earlier. 63.5% of all the benefit reductions were for people over 65. And that's due to the different eligibility rules for Medicaid programs when someone has Medicare as well. We can go on to the next slide. When we looked at disability status specifically, we saw a higher percentage of people with disability, 89% retained benefits compared to people without disabilities. That was an 82% average there. So that was glad to see that there. We also saw that we were particularly more likely to get responses from them. Only 21% of this population closed for not responding or not providing them requested info in the process compared to 37% of the overall population. We did some additional efforts to reach OSIPM members during this process, people on age and disability-based Medicaid, such as doing active outreach calls to schedule interviews. And this point here suggests that those efforts were effective in helping people respond and not lose benefits due to not providing information. We can continue on to the next slide. And when we look at housing status, we saw that unhoused people were more likely to retain benefits than housed individuals overall. That is partially due to income, most likely. We did see that they were, on the other hand, less likely to respond to the process, which reflects the additional difficulty of contacting people who don't have stable addresses. So we saw them retain benefits at higher rates, though there was some response difficulties there, and continuing that outreach support through partners like CPOP or their community partner outreach program assisters is an important way to continue reaching those members. We can continue on to the next slide. There were also specific priority eligibility groups that we wanted to look at specifically. The Oregon Supplemental Income Program is one of our main age and disability Medicaid categories. And within that, there's a subset of members who are receiving long-term care services. Both of those groups kept benefits at an 85% rate, higher than the overall 83% average. We also saw Medicare Savings Program only members keep benefits at a nearly 90% rate. So that was a significant difference there between the overall population. So the priority groups, we did see retain benefits at higher rates, which again reflects that additional support we provided in the renewal process to make sure that these members were able to keep benefits whenever possible. We can continue on. When we look at reasons for closure, the top two reasons were financial and age requirements, and then the missing requested info. There's also a other program requirements category, which is a very broad category of people who moved out of Oregon or no longer meet other requirements. For instance, Medicare, having Medicare can fall into that one too. Those are the top reasons for closure there. We also have some that were voluntary closures where they actually requested us close their benefits. About 4,000 members had deceased since the pandemic, their last renewal during the prior to the pandemic. And we also had about 1,600 who are incarcerated or in jail or state institution, or and then we have a few smaller categories of missing required activity, like an interview, and people who have out-of-state Medicaid in another state. Can move along. So adding that up, we ended up with either the first or second highest renewal rate in the nation. There are some areas we can look at to continue to refine our outreach and activities and find areas where we aren't just reaching as other parts of Oregon as effectively, that we can continue that continuous self-improvement process. Otherwise, the main reasons we saw people losing coverage were financial requirements, which makes sense. People's income changes over time. So that was kind of as expected, but there's a lot of steps we took to keep that renewal rate as high as it was, and we wanted to celebrate that and learn from this process what we could, since it gave such a good insight into the renewal process, as we have extra tools during the pandemic to analyze all of this, and wanted to continue that forward and see what we could do to learn from that. So that's our analysis there. Happy to take any questions and whatnot if the group would have any.
Members of the MAC, are there any questions?
This is Heather Jeffress. No question, but I just really want to emphasize over the years, seeing all the hard work and infrastructure that was put in place by your team, Sean, to get to these results is really exciting. So thank you you made it look easy in your report because you have all the perfect data there and you have wonderful outcomes, but all of us on the MAC, I just really having the opportunity to watch the process over the years and your team's preparations for this, you really did an excellent job of putting in the infrastructure to meet the needs of the OHP members and putting in infrastructure to meet the data questions that we've asked of you over the years. So really, thank you. Excellent report, excellent work. Really appreciate it. You should all be proud.
Thank you. A lot more people involved in that than just me.
Similarly, I appreciate the comparison data to other states in the country to know how Oregon has performed in this realm compared to other states. I know this has been, there's been a lot of consternation about some individuals losing eligibility. And so appreciate the comparison data. So thank you. Other members of the MAC, are there any questions or comments?
Yeah, I'm just off topic, but I think relevant.
Sorry, Jerry, you're really quiet.
Oh, yeah. What's that? I think this is a little bit off topic, but I think relevant to what's going on and what Emma Sando presented a little while ago. Are you able to break down, like, out of the 1.1 million Medicaid members by who has ACA and who has traditional Medicaid? Because I think the cuts, if they go through, impact those two populations, could impact them very differently. I'm wondering if you're looking at, yet, even though we don't know what the cuts might be, if you're looking at that data and trying to run out the financials on that, or is it soon to tell?
Sean, would it be helpful if I?
Yeah, I'll let you take that one if you'd like.
I think that is a really key question, and it would be something that we would need to do some analysis with our financial team. So we might not be able to have that by the next MAC meeting, but we'll see what we can do to get some level of analysis for you at a future meeting. I think one thing that I would note is we're not entirely sure what the congressional things would look like, but I think what you're asking for is sort of what we're spending aligns based on eligibility group, and that's something that we've presented in at the legislature in the past, so we can pull that up for a future MAC meeting.
Thank you.
Other questions from members of the MAC? Well, we have a few minutes. Are there, I know Carmenia, you had, I believe, wanted to speak in this section. I'd welcome you to speak now.
Yes, hello. My name is Carmen Anchala, excuse my voice. I have a question regarding, was there any data performed on the HRSN program that helps with housing through the OHA? I have Kaiser. And so it was really difficult for me to get any help when I moved. And I don't see any, I'm not understanding if there's any data that shows when you have Kaiser and trying to get help through the programs that are linked into OHA, what there is out there. It was really difficult for me, and I'm disabled. I don't see it. I don't know. I don't understand why there isn't any more screaming about that situation. Should I
Thank
say?
you for sharing your experience and for being here today, Carmenia. I'm
Thank you.
sorry to hear. We always welcome having members of the public and OHP members. I'm sorry to hear it has been such a challenge for you. I know coming up at 10:30, we have a couple of presentations specifically about HRSN. That's the second half of our meeting is specific to HRSN. So I'm not sure if your question will be answered during that time. If it's not, Sarah, would you know, or Sean, would you know who would be a resource for Carmenia to reach out to attempt to answer her question?
This is Kaya from CHA. I can touch base with her afterwards if her question isn't addressed. I help run the HRSN program down here in Klamath. And so
Wonderful.
we have CCOs here, and then we have transferred members up to Kaiser successfully, and they were
Wonderful.
able to access their benefits. So if your question isn't answered in that forum, then I can circle back and talk to you if you'd like.
Wonderful.
Okay, thank you.
Thank you, Kaya.
Mhm.
We do have a few more minutes. I'll circle back to MAC members. Any other questions, comments from MAC members? Any other questions, comments from the public right now? Okay, well, thank you so much, Sean, for presenting this data and summarizing the really hard work that your team and OHA have been doing the last 5 years. Thank you very much. So I apologize, I'm getting lost in my timeline here. Let me scroll back up. So next is Erica Kosher, are you online already? We're about 5 minutes early. If not, we can pause for a few minutes.
Hi, yes, I'm here and ready.
Okay, so next we have Erica Kosher from Healthcare Market Oversight from OHA to talk about the Legacy Health Foundation Pacific Source Form A presentation. Thank you, Erica.
Thanks. My name is Erica Kosher, and I am with the CCO Form A review program at OHA. Thank you for having us here today to talk to you about this proposed transaction that involves Pacific Source. Go to the next slide, please. Just a little bit of background about what CCO Form A is and what it refers to. Oregon Health Authority is required to review certain transactions that involve coordinated care organizations, such as mergers and acquisitions, to make sure that they promote the interests of Oregon Health Plan members and all Oregonians. This review process is referred to as CCO Form A. The name comes from a somewhat parallel review process that the Department of Consumer and Business Services conducts. And that is when there is a proposed transaction that involves a domestic insurer. In 2019, there was legislation passed that authorized OHA to conduct a similar review process with respect to coordinated care organizations and adopted rules that align with DCBS's process, as well as added some additional requirements. Our review program looks at several factors to evaluate the impact of a proposed transaction on the coordinated care organization, and OHA has the authority to approve with conditions, or deny a transaction. Go to the next slide. We are here today because our rules require us to seek feedback from the Medicaid Advisory Committee. And so we are currently reviewing a proposed transaction that involves Legacy Health Foundation, and Pacific Source, which operates several CCOs here in Oregon. So we are here to provide you with information about the proposed transaction, the CCO Form A review process, and how the MAC and members of the public can provide feedback to us to use in our review, or raise any questions that you may have about the transaction. Next slide. There are other regulatory reviews currently going on with respect to the same transaction that you may have heard of. So wanted to give a little bit of background about how the different regulatory reviews work together. As I mentioned, DCBS has its own Form A review when a domestic insurer is involved. So here, Pacific Source has Medicare Advantage and commercial lines of business, and so they are reviewing that part of the transaction, and we are required by rule to work with DCBS to jointly analyze the proposed transaction. Transaction involving a coordinated care organization may also require review by OHA's Healthcare Market Oversight Program. And so there is also a review going on under the HCMO program as well. Next slide. Just at a high level, the differences between CCO Form A review and DCBS's Form A review. OHA's CCO Form A review focuses on the coordinated care organizations, and DCBS focuses on the commercial and Medicare Advantage lines of business. CCO Form A review also looks at a number of additional factors in its review related to cost, access to care, quality of care, and equity. Next slide. Our review process begins when entities are proposing to enter into a transaction, such as a merger or an acquisition. They file a notice with our office, and that includes all kinds of information about the proposed transaction. We then can ask the entities that are parties to the transaction more questions to learn more about how the transaction will work and how it will impact the coordinated care organization and members of the CCO plans. We also can engage subject matter experts and outside advisors to help us analyze the transaction. We work jointly with DCBS, as I mentioned, and then we also engage both the MAC and the public for input on the transaction and how it may impact CCO members. This process can take 6 months or longer and before we issue a decision. And when DCBS is also involved in the review, OHA's CCO Form A will issue its decision concurrently with DCBS. Next slide. In our review, the CCO Form A program looks at how a proposed transaction will impact a number of criteria. And so that includes how a transaction might impact the financial stability of a coordinated care organization, its ability to provide services within the state cost growth limits, ability to innovate, coordinate care, provide value, deliver high quality services without barriers to access. We also look at how the ownership or governance of the CCO, whether that would continue to satisfy state and federal requirements, how the transaction might impact the CCO's relationships within the community, the CCO's ability to equitably serve diverse populations, including underserved populations, ability to support social determinants of health, impact of the transaction on access to and quality of healthcare for both OHP members and all Oregonians, the ability of the coordinated care organization to continue to perform its contractual responsibilities under its contract with OHA, and its ability to advance OHA's policy goals. Next slide. OHA has the authority to disapprove a transaction under a number of criteria. So if OHA finds that the proposed transaction meets any of these criteria, there is authority to refuse to approve, and that includes finding that the transaction would be contrary to law, inequitable or unfair to CCO members or shareholders, that the CCO would not be able to satisfy its contractual commitments. It would put the financial stability of the CCO in jeopardy. If there are plans to sell or merge the CCO or make any other management or structural changes, that would be unfair or unreasonable or not in the public interest. If there are risks of not complying with state and federal laws, if the transaction would put the competence, experience, and integrity of the persons that control the CCO in question in terms of whether that would serve the interests of the CCO members and the public. if the transaction is likely to be hazardous or prejudicial to CCO members, other Medicaid members, or other Oregonians, whether the transaction would be likely to reduce the CCO's commitment to addressing health disparities or inequities, making it more difficult to achieve health equity, or if the activity is subject to other material and reasonable objections. Next slide, please. OHA can also disapprove if it finds that the proposed transaction would substantially reduce the security of and service of the CCO to its members, access to and quality of healthcare for Oregonians, or substantially increase the cost of healthcare, or the ability of the CCO to perform its contractual obligations, innovate, coordinate care, provide value, deliver high quality services, demonstrate its commitment to addressing health disparities and inequities, be strongly connected to the community served, provide its services cost effectively, support social determinants of health, and satisfy the Oregon Health Policy Board's priority policies. Next slide. So to turn to the transaction that we are currently reviewing, I can give you some background information first about the parties to the transaction. I want to click forward about 2 slides, please. So the parties to the transaction involve Legacy Health Foundation, and Pacific Source. Pacific Source is a nonprofit company that owns Pacific Source Community Solutions. And that is a company that contracts with OHA to administer CCO plans. Pacific Source also owns 2 other entities that offer commercial and Medicare Advantage plans. Pacific Source is currently 50% owned by Legacy Health and 50% owned by Pacific Health Associates. Pacific Health Associates is a nonprofit organization that provides grants and collaborates with Pacific Source on grant opportunities. The Pacific Source board is currently comprised of 6 directors that are appointed by Pacific Health Associates, 6 appointed by Legacy Health, and 3 that are appointed jointly. Next slide. As I mentioned, Pacific Source serves CCO members in 5 different service areas. This includes the Columbia Gorge, Central Oregon, Lane, and Marion Polk CCO service areas, as well as a portion of the Portland metro region under a contract that Pacific Source has with HealthShare as a risk-bearing entity. Next slide. Legacy Health System is a nonprofit health system that owns and operates 6 hospitals in the Portland and Vancouver metro areas and Mid-Willamette Valley, as well as 70 outpatient clinics. And they are currently a 50% owner of Pacific Source. Next slide. Legacy Health Foundation was established in 2013, and Legacy Health is the sole member of Legacy Health Foundation currently. The foundation engages in fundraising and supports the mission of Legacy Health by funding community organizations, programs, and services that are not supported by traditional payments. Next slide. Next slide, please. So the proposed transaction that is under review and that we are asking for feedback on is that Legacy Health plans to spin off its foundation into an independent foundation that would be separate from the Legacy Health system. And this foundation would become a grant-making foundation as opposed to fundraising. Legacy Health would then transfer its 50% ownership interest in Pacific Source to Legacy Health Foundation, along with Legacy Health's remaining net cash after closing of the proposed OHSU transaction, which is related but separate to this transaction. And I'll speak more about that in a bit. And the end result of this transaction is that Pacific Source would now be 50% owned by Legacy Foundation as opposed to Legacy Health System. Next slide. In terms of what the foundation will do following the transaction, according to the entities, as I stated, they will serve as a 50% owner. They will be a grant-making entity. They will be separate from the proposed combined OHSU legacy system. And the foundation would be comprised of 5 current legacy health directors and 4 current foundation trustees. Next slide. In terms of its grant-making activities, there are some restrictions on how the foundation must use the grant funds that it will receive. The foundation is required to use the grant funds to support the foundation's mission and vision in Oregon and Southwest Washington, including for grants to nonprofit organizations, tribes, agencies, educational institutions, OHSU, and other hospital-based systems in furtherance of the foundation's mission, foundation's programs, costs, and activities, and also operating and administrative costs. The foundation may not use the grant funds for organizations with a primary focus and operations outside of Oregon and Southwest Washington, or for the benefit of any hospital-based health system that is in competition with the OHSU system for the purpose of engaging in activities that are competitive with the OHSU system. The foundation will also be prohibited from soliciting donations. Next slide. In terms of what this means for Pacific Source, according to the entities, the foundation does not plan to make any corporate governance, managerial, or operational changes at Pacific Source. The foundation will assume Legacy Health's current right to appoint 6 members of the Pacific Source Board of Directors. And over the next 5 to 10 years, the foundation intends to seek a buyer for its 50% interest in Pacific Source. Next slide. So one question you may have is whether this is related to the OHSU legacy merger that you've probably heard about. The transaction is related to, but it is separate from that proposed transaction. The proposed transaction between OHSU and Legacy is currently under review by OHA's Healthcare Market Oversight Program. And that is a separate review program and process. According to the entities, OHSU determined that acquiring Pacific Source did not align with its long-term strategic objectives. And so that is why this aspect of the transaction is excluded from the OHSU legacy transaction. The OHSU legacy health transaction is not subject to CCO Form A review. CCO Form A review is only triggered when it involves change of ownership or control of a coordinated care organization. If approved, the entities will close the transfer of Pacific Source's 50% ownership interest to Legacy Foundation upon or immediately prior to the closing of the OHSU Legacy Health transaction. And according to the entities under the proposed terms, the Legacy Foundation Pacific Source transaction will not proceed unless the OHSU Legacy Health transaction receives all of its required regulatory approvals and vice versa. Additional information on the OHSU and Legacy proposed transaction can be found on OHA's Healthcare Market Oversight website, as well as ways for the public to provide input. Next slide. If you have additional questions about how the legacy and Pacific Source transaction works and impacts from that transaction, you can read more about the transaction on the CCO Form A website. On that website, you'll find the initial filing submitted by the entities, which has a significant amount of information, as well as responses to questions that the CCO Form A program jointly with DCBS posed to the entities and received responses, written responses from, and supporting documents. So all of that can be found on our website. Next slide. Our role in reviewing the proposed transfer of the 50% member interest in Pacific Source to Legacy Foundation is to conduct our review under the statutory review criteria, determine whether to approve with conditions, or disapprove. Our review really focuses on the impact of the transaction on Pacific Source's CCOs. We look at the information submitted by the entities, information provided in response to questions we asked, publicly available information, public comment, feedback from the MAC, and from the Pacific Source Service Area Community Advisory Councils. And once we've received all of the information that we deem necessary, CCO Form A will issue a decision in conjunction with DCBS. Next slide. Next slide. In terms of next steps, we are seeking feedback from the Medicaid Advisory Committee regarding this transaction. We would invite the committee to provide a recommendation to the CCO Form A program regarding whether to approve with conditions, or disapprove the transaction. We plan to seek a recommendation at the committee's June 25th meeting, or at another meeting if requested by the MAC. We also invite the committee to identify any questions that it would like the CCO Form A program to ask of the entities about the transaction. And we would request that if the committee has questions for the entities, that it submits those to us by June 6th to give us time to compile those. Next slide. The public can also provide feedback, which we welcome in a couple of different ways. We will be holding free virtual public listening sessions. At the first two sessions, we will be providing the public with opportunity to provide public comment. Members of the public are also invited to raise any questions that they would like the CCO Form A program to ask the entities about the transaction. These two sessions will be held, the first one on May 29th at 12 p.m. and the second one June 5th at 5:30 p.m. We will then hold a third public listening session where we will invite Legacy and Pacific Source to speak to the public and answer questions that we have compiled from both the Medicare Advisory Committee and other public comment, both written and from the listening sessions. And that will be held on June 16th from 1 p.m. to 3 p.m. Next slide. The public is also welcome to provide feedback through written public comment at any time about this transaction, or also propose any questions that you may have for Legacy or Pacific Source. And comments or questions can be submitted via email, our voicemail, or we have forms on our website where you can submit public comment or questions. Next slide. And finally, you may be wondering when CCO Form A will make a decision regarding this transaction. Because there are other regulatory reviews currently in the process as well. Those review streams coordinate together in terms of the decision timing Here, because the healthcare market oversight program is also reviewing the transaction, that they will complete their review first and then make a recommendation to DCBS. At that point, DCBS and CCO Form A will coordinate, share information and findings, and DCBS and the CCO Form A program will issue a decision concurrently. Next slide. All right, thank you very much for allowing us to come and speak to you today about this transaction. I'm happy to answer any questions about our process or how the committee can engage with us.
Thank you, Erica. We just have about 5 minutes left. You answered most of my questions going through the process. One question that did come up for me, and in full transparency, I am a full-time employee of OHSU. Is the proposed OHSU legacy, or do you know if the proposed OHSU legacy merger is contingent upon approval of this Form A transaction of legacy, however, the Legacy Foundation Pacific Source? Do we know that information?
According to the entities and how they've structured the transaction, is that both transactions must be approved for them to go forward. So
Okay.
one transaction is not approved, then the other would not occur, and vice versa.
Okay, thank you. Lisa, I believe you had your hand up first, and then we'll go to Tony.
Yeah, I have a question. So this $350 million is under item 4, and it says see exhibit 4 for a summary of the net cash calculation. I don't see an exhibit 4. So how are we supposed to give, meaningful input on this application without knowing where they're getting $350 million that's being transferred out of the CCO?
Yes, so I think that is a great question that we can take back and include in our questions that we would pose to the entities to get more information about. We try to post all of the information that entities submit to our website. There is some information that is protected by confidentiality under the law that we cannot post. And so that may be some of the information that you are trying to find, but yes, that's a question that we can pose to the entities.
Thank you, Tony, and then Heather.
Yeah, and thank you, Ms. Kosher. Appreciate the presentation here. I was curious, on with HCMO's review of a number of different acquisitions and mergers in the state, the Community Review Board is held. And I know there was an attempt for this particular merger. I just wonder if you could comment on the process of that. One, just being transparent in the state, and it sounds like in this forum with the MAC having some opportunity to serve in this role, but just wondering about the intentions and how we make sure that people are well informed of community members and how best maybe this group can serve in that role.
Sure. And so, with respect first to the CCO Form A process, we're have set up a number of avenues for the public to provide input to us, and we really welcome feedback from any in any manner from any group. And if Sarah Bartleman is on, I will let her speak to the HCMO process and Community Review Board process for that review program.
Thanks, Erica. Hi, everyone. I'm Sarah Bartleman. I manage the Healthcare Market Oversight Program for the Oregon Health Authority, and I can speak to that part of Tony's question. On the HCMO review of the Legacy Pacific Source transaction, HCMO did initially pursue convening a community review board. So similar to this request for the MAC, it would be a group of members of the public. There are specific criteria in terms of who HCMO would include in a community review board. And we did a pretty robust recruitment call for members to be part of that community review board. And we really didn't receive any applications from CCO members, from Pacific Source members, and those folks that would be maybe directly affected by this change in control. And so OHA decided to ultimately not convene a community review board on the HICMO side because we knew that there would be other avenues because this transaction is subject to these multiple review paths that Erica explained. We knew that we would be coming to the MAC under the Form A review for a recommendation. We knew that we would be holding some of the listening sessions that Erica also described. And so we ultimately decided not to move forward with pursuing the community review board on the HICMO side in addition, because we really were receiving a lot of interest in folks that wanted to talk about OHSU legacy and folks that wanted to talk about the foundation and the foundation governance. And we really weren't hearing from people who were Pacific Source members, and we wanted to make sure that that voice was part of the review.
That's great, Sarah. Yeah, thanks for that feedback. I think just in reflection and looking at the listening sessions, that's terrific. A number of those three. I do wonder in this context of having that information and the MAC being informed when they're coming together to make this decision to do this review. I know there is some context of prior subcommittee work. I just wonder if the MAC should take that under consideration in this context, given that this is one of the largest, well, two separate mergers, right? But this will be one of the largest mergers in the state of Oregon. And with reflections just specific to the foundation, with that amount of money and the number of people affected, that might be something for this committee to think about as they've done in the past.
Thank you, Heather, then Kelly, and then I think we will need to pause for our break.
The Tonys. My question is really more of a comment to follow up with Dr. German's comments. I have some pretty detailed questions, and so do we need to move to make a subcommittee? I might be, that's my query to staff and to Caroline, because I think that
that would be my inclination as well, Heather. I think
Yeah.
this is a very large topic with potentially massive implications.
Yeah. So
uh,
that would be my suggestion, and I'd be happy to do that when it's appropriate, so that we can get our questions to the team before the June 6th deadline that they need our questions by. Is that correct, Erica?
Is the June 6th deadline? Okay, so I was going to say, why don't we have Kelly speak and then we can circle back around to move to make a subcommittee. Does that sound okay?
Perfect. Thank you.
Okay, Kelly?
Thank you, Caroline. I just wanted to call out and certainly welcome the questions that will come forward around this process. Just two pieces in terms of some of the language I heard in follow-up questions. One, to clarify that in this transaction, money is not coming from the CCOs to go to the foundation. So just being very clear about that, it's not Pacific Source CCO, Pacific Source Community Solution funding that is being moved in this transaction. The second piece I would call out is would hesitate to use the term merger as it relates to Pacific Source. It's really a transition of a partial ownership of a holding company and subsidiaries downstream that hold the contract with the CCO, but is not a merger of Pacific Source.
Thank you for those clarifying points, Kelly. I think that is language is very important. So thank you for that. Lisa, briefly, and then we'll circle back. Lisa?
Yeah, I just want to read here. It does say that Pacific, the 50% interest that Legacy Health holds in Pacific Source is going to the foundation. That I think that's included in that 350 million. It says Legacy Health will transfer to the foundation all of its net cash, as well as Legacy Health's 50% member interest in Pacific Source. So that is CCO going to the foundation.
I think this, sorry to interrupt you, Lisa, but I think this brings us back to Heather's point of, I think we need a subcommittee to write out thoughtfully these questions to bring them to OHA. So Heather, would you like to make your motion?
Yeah, I would like to move that the Medicaid Advisory Committee create a subcommittee to develop a set of questions to submit to, oh my goodness, the Healthcare Market Oversight Team before the June 6th deadline. Is that correct, team? No later than the June 6th deadline for them to give us timely response.
Do I have a second?
Caroline, if I may, can I ask a clarifying question about Heather's motion?
Please.
Would the MAC subcommittee only be looking at the questions, or would the MAC subcommittee also be helping inform the MAC recommendation?
Thank you,
I
Sarah.
think-
That would be very helpful. We will also please amend that motion and include the scope of the recommendation also. Thank you.
Thank you. I will second that if that is allowed. Are there any objections? Any abstentions? The motion carries. Sarah, if anyone would like to volunteer for this subcommittee, I would ask you to please message Sarah. Sarah, if you would also please send out a follow-up email to the MAC members soliciting volunteers, that would be fantastic.
And
So I thank everyone for this very vibrant discussion. This is a big topic, and thank you for our presenters for being here. So we will now pause for a break until 10:30, and come back at 10:30. Is that right, Sarah? Because I thought we were switching, or is it 10:25? 10:30.
If we want to have 10 minutes, let's come back at
Let's say
10:30.
10:30, or let's say 10:27, make it 6 minutes, get close.
Sounds
10:27. Okay. See you all in
Thanks.
6 minutes, 5 or 6 minutes. Bye. The Social Needs and Analytics Projects team, are you here ready?
We are. Thank you.
Thanks so much for being here.
Absolutely. So good morning. Thank you all for having us today. My name is Amanda Peden. I use she, her pronouns, and I have the pleasure of working with the Social Health Needs and Analytics Projects team, or the SHNAP team here at OHA. Our small but mighty team is responsible for data and analytics in a few areas of the Medicaid program, including child and youth benefits, social resource referrals, and the topic of today's presentation, which is Medicaid health-related social needs benefits. So I'd like to take a quick moment to give my colleagues a chance to introduce themselves. Anna, do you want to go first?
Sure. Hi, everyone. Thanks for having us. My name is Anna Menon. I use she, her pronouns, and I am the HRSN analytics lead. And our colleague Sonia is here too. Go ahead, Sonia.
Hi, everyone. My name is Sonia Faruqi. My pronouns are she, her, and I am the lead research analyst on the SHNAP team.
Thank you. All right, next slide, please. So for today, we're really excited to bring you a look back at some of the early data we have on the health-related social needs benefits as they've rolled out over the past year. What we hope to provide today is a look at the type of early analysis we're doing and to gather your ideas for what data you'd like to see in the future. So we'll start with a brief overview of health-related social needs. We'll review some of the data that we have available at this time, and we'll close with some areas we hope to explore in the future, as well as discussion with you all. And you'll see as we walk through that a lot of the data we'll be sharing is from the early months of the program. So we have very limited data to share on the housing benefits that launched in November, for example. We're working hard to get updated data and stories related to benefit use in 2025, as well as more demographic analysis on race, ethnicity, language, disability, sexual orientation, and gender identity. And while we don't have more recent data to share today, we know that our colleagues in OHA's Ombuds program may have more current data on member experience to share later in the meeting. So we have a lot to share today. We'll be moving quickly. If you have questions as you go, especially clarifying questions, and you feel comfortable, feel free to drop those in the chat. We'll monitor those, try to answer as we move along. And we appreciate you holding more detailed questions until the discussion. So I will, with that, pass it over to Anna.
Thanks, Amanda. So as Amanda said, we're going to start with a brief overview of what health-related social needs benefits are and the different data we're collecting. So these Medicaid benefits are for certain transition populations. Some HRSN benefit examples are rental assistance, devices for the home, such as air conditioners, air filters, nutrition support, and then help connecting to other services. Go to the next slide, please. So the health-related social needs data, we call it HRSN, so you'll hear that acronym a lot, HRSN data. It really comes from a lot of different sources, from traditional claims data to a variety of contractor reports to feedback collected and stored by OHA's many public-facing teams. The Ombuds team is one of those. So our analytics will draw from all of these different sources and try to develop a picture of HRSN processes and impact. Next slide, please. And I just want to reiterate, because all of this is new and there's some complexity from mixing all these different data sources, getting to reliable data is taking a little bit of time. Can go to the next slide, please. We are looking forward to being able to answer a variety of questions about how the benefit is rolling out. We've already been drawing on preliminary data and producing analysis from the sources we have. And I'll just draw out a few of these, leaving more about which members may be eligible for HRSN as part of a covered population, seeing who is getting services and who isn't. We can go to the next slide. Actually, we have it a little bit pared down for you. Perfect. So today, we'll see some early information about which OHP members are in a covered population, what services are provided, who's getting those services, what does our provider network look like, and then very briefly, what some members are saying. Go to the next slide, please. And I'm just going to reiterate super briefly for this presentation, we're just giving a sense of the types of analyses that we're working towards. And so in this section, we're going to explain our start to understanding HRSN eligibility. So before we share some early estimates, we have of the members who fit into HRSN covered populations. I just want to make it clear that the covered population is just one part of HRSN eligibility. Members also have to meet clinical and social risk criteria that vary based on the service they're requesting. Next slide, please. Great. So it's a little bit of a busy graph, but the main takeaway here is that to be eligible for HRSN services, members need to be a part of one of 7 covered populations. So you can see those coming off in the ribbons to the right. And about 1/3, based on what we've seen, about 1/3 of enrolled OHP members had data that indicated that they belong to an HRSN covered population. And the main takeaways here really is that that 1/3 number, and that the largest populations we're seeing so far are those who have been discharged from a behavioral health facility, those who are experiencing homelessness, and those who are at risk of homelessness. Okay, we can go to the next slide, and I think I can pass it over to Sonia.
Thanks, Anna. I will be sharing what HRSN services have been provided and who is getting these services. Next slide. Thank you. HRSN benefits are available now and have been available since March of last year. The goal of the HRSN Home Changes for Health benefits is to keep people safe during extreme weather and wildfire smoke events. Eligible OHA members can receive air conditioners, heaters, and air filters to provide clean air and health temperatures. Eligible members can also receive mini refrigerators to keep medication cold during power outages, as well as portable power supplies to operate medical equipment such as portable oxygen machines. Next slide, please. Thank you. This slide includes information on the devices delivered in the first 5 months of the program, so between March 1st and July 31st of 2024. From the beginning of the program through midsummer, more than 3,600 devices were delivered to more than 2,000 eligible Oregon Health Benefit members. Excuse me. The most frequently delivered devices were air conditioners, making up 46% of devices delivered, followed by air filtration devices at 25%. As a reminder, members can receive more than one type of device to promote improved health outcomes. Next slide, please. Okay, we won't spend too much time on this slide, but it looks at utilization based on age. We have started some analysis on demographics using the limited data we currently have. However, we do plan to do more in-depth analysis once we have REAL-D and SOGI data on HRSN benefits. Next slide, please. This slide shows which counties had the highest ratio of members who received home changes for health devices. The darkest blue areas, Columbia, Douglas, and Calumet counties, had the highest ratios compared to their total number of OHP members. Wallowa County had no services delivered. We don't know the distribution of eligible HRSN members yet, and we don't know about need across the state. So it's difficult to get a picture of whether this distribution right here is reflecting eligibility or need. Next slide, please. This slide shows the percentage of members enrolled in a plan that received home changes for health devices. Right now, we can show what's happening, just like in the previous slide, but we don't fully understand why it's happening. Over the next 2 years, we'll be working more to bring in qualitative data to assess the underlying needs so that we can better understand the variation we are seeing. Next slide, please. Now we want to share the very limited data we have on the HRSN housing benefits. OHA and MEM plans are still working together toward more complete data on housing benefits. The data we are presenting is from a very brief survey that all CCO and Open Card took that covered the first 2 months of the housing benefit in November and December of 2024. The survey asked for very limited information. We expect to have more complete data to share this summer. And just a reminder, housing benefits for eligible OHA members include forward rent, forward utilities, back payments for rent and utilities, storage fees, home modifications, and utility setup. Next slide. This slide visually represents the volume of requests, authorization, and denials over the 2-month period. So that's the November and December during the rollout in 2024. What we saw from the limited data was that it was a huge volume of requests and that these requests were taking longer than expected to move through the process to be authorized and for the services to be provided. By the time of the survey, many requests still had not been completed. Thank you. This story comes directly from a CCO, and we received special permission from the member to share it. We've been very thoughtful and intentional about how to collect and share qualitative data and stories, but we're still in the process of setting up our internal systems to collect and report qualitative data consistently. This is just one example of the impact we're seeing. There are many others like it. However, we know this doesn't fully capture the challenges some members are facing with the new program. Our goal is to develop a much richer and more complete picture of qualitative data moving forward. And I'll pass it to Anna.
Thanks, Sonia. I'm going to take us through a few slides on our HRSN provider network. And then it looks like we have a good amount of time to field some questions after. Okay, so we can go to the next slide. Perfect. So HRSN provider networks have grown steadily, is what we've seen. And to give just a tiny bit of context, providers here, we don't mean clinical providers necessarily. Providers really mean community-based organizations, local public health authorities. It's a much broader definition for HRSN services. So we saw, especially around November, a good increase in available providers that were enrolled with OHA. Next slide, please. I wanted to call out that OHA is tracking our HRSN provider network in the OHA strategic plan. They are both linked. I see you can't click on the links in the slide. We'll drop them in the chat for you. And I believe you have access to the slide deck in the meeting invite. But the first link, you can read more about our strategic plan. And the second, you can see the dashboard where we're tracking HRSN providers hosted online. All right, we can go to the next slide. I'd like to take you with where we see our analytics program going over the next few years. We really hope to explore why members are being denied. Currently, we only have a few quarters of data and we're going through quality assurance with them. We're interested in exploring how members are requesting HRSN services, how they're getting rooted into the program, investigating if there are any gaps within the HRSN provider networks, either geographically or linguistically. As two examples, are there differences in requests, authorizations, utilizations, and denials across Real D and SOGI categories? So across race, ethnicity, gender, language, or disability status groups. And then we really wanted to hear from you. So what else are you interested in learning about? And we can go to the next slide, please. What other questions do you have about HRSN? Any way we can guide our analytics to support that?
Thank you. When I was reviewing these slides yesterday, I was really appreciative of the very specific data that you have provided. I know it's early days in terms of the data collection, so thank you for, I appreciate that there are still a lot of questions to be answered, but you're providing a lot of data. I was wondering if one of the questions I have is kind of with the top service providers from the CCOs, if we know what they are doing that some of the lower performing or lower offering, if that's perhaps a better word, CCOs are doing, if that is an area of exploration that we could collect data on as well. But I just want to reiterate appreciation for the very specific data report. Other MAC member comments or questions?
I would echo what Desiree has said in the chat, and I have some sort of real life examples from our F2HC that I'm happy to pass on to whomever would like that to make the process more streamlined.
As someone who does a massive amount of admin, I fully support streamlining the ability to track data. It is a common concern of my own in my line of work. So yes, while I'm a big fan of data and just was saying how much I love all this data, streamlining that acquisition of data, absolutely support. Thank you, Jerry and Desiree, for calling that out.
Yeah, Jerry, if you want to send whatever to me, I'll figure out who in OHA needs to get it.
Yes, fully support that. Heather.
Yes, I'm gonna ditto that. In my day job as a executive director for a nonprofit trade association of behavioral health providers, there is looks like from the chat there's similar testimony, but any way to support ease of application and data collection from providers out in the community would be greatly appreciated. I think some of our questions that the Medicaid Advisory Committee had for the program before still kind of stand around general confusion and difficult processes that are continuing in communities to access this new program. So, thank you.
Time for one more MAC member question, comment. Wonderful, thank you. While we have more room for growth and improvement, we appreciate your time of reporting what the progress has been made. Thank you so much. Now we will be moving on to the health-related social needs external review update with Hannah Cohen-Klein. Thank you for being here.
Hi, thank you. I think we're still a few more slides down. There we are. Yes, thank you. Good morning, everyone. I am Hannah Cohen-Klein. I use she, her pronouns, and I am from the Center for Outcomes Research and Education. I'm joined by two of my colleagues today, Maggie and Claire. We are collaborating with CHSE at OHSU to do the external evaluation of Oregon's 1115 Medicaid waiver. And I am here today to talk specifically about some work that we're doing around a survey that will go to OHP members who have received HRSN benefits and it to ask for a bit of support in developing out this survey. Next slide. I will go over a very brief background. The SNAP team just did a wonderful job of giving a background on HRSN, so I will modify what I am saying accordingly to not repeat. Talk a little bit about the evaluation and then talk about the survey testing that we are hoping to do. Next slide. So background on the waiver evaluation. Next slide. So we at CORE have been contracted to evaluate 4 of the policies that are currently in the waiver. There are 2 others, which you'll see on another slide, but really what I want to focus on today is the HRSN policy and the evaluation that we are planning on conducting over the next several years. Next slide. So every 1115 waiver has to be evaluated by an independent party, not by the state. That is why CORE is involved, and that is why we are collaborating with CHSE on this. And the Centers for Medicare and Medicaid Services provide a starting list of evaluation requirements that need to be included in the evaluation. And then as part of designing out the evaluation, CORE worked with OHA and a number of other interested parties to really understand what other questions outside of what CMS was requiring would be of interest in evaluating the impact of the different policies within the 1115 waiver. And our evaluation timeline goes through the beginning of 2029. So there's about a year and a half after this iteration of the waiver ends where we are still going to be evaluating the impacts of it. Next slide. So this diagram shows the 6 components of the waiver. And again, you can see what CORE is working on, what CHSE is working on, but really we are focused today on talking about the HRSN evaluation. Next slide. So our evaluation has a series of questions that are around the implementation of HRSN that I am not going to talk about, but I do want to say that we do have quite a bit that's focusing on understanding how this particular policy is being implemented across the state. And then we have questions that are really focused on understanding the impact of the HRSN policy on OHP beneficiaries who receive HRSN benefits. So this is understanding both how the demonstration impacts the use of health-related social needs services and the rates and severities of these health-related social needs after the services have been distributed, as well as understanding the impact that the services are having on use of healthcare and on physical and mental and behavioral health outcomes. And then you can see in all of these questions, we also have a question that is really specifically trying to understand the impacts that the demonstration is having in inequities in each of these different outcomes. Next slide. We are evaluating these outcomes through a handful of different types of data collection and analysis. And I'll talk a little bit more about the survey that we are designing in a moment, but we are designing a survey to be fielded to HRSN beneficiaries in 2026 and 2027. We are also conducting interviews with beneficiaries to understand more about the experience that they are having in obtaining HRSN services, as well as getting some more nuanced information on the impact that it is having on healthcare, and social needs. And though we are doing quite a few interviews over several years, so we anticipate talking to, I want to say it's around 180 HRSN beneficiaries. And then we are looking at some administrative data, so Medicaid claims to understand the receipt of HRSN services and the impact on healthcare utilization, as well as examining the CCO flexible services before and after HRSN implementation to understand how health-related service delivery has changed with the implementation of the waiver. So focusing in, next slide. So focusing in a little bit on the survey and what we're asking for today, we are designing out currently a survey for housing benefits, so rent, utilities, as well as the home changes. That was the air conditioners, heaters, air filters, that sort of thing. We anticipate a nutrition survey coming later after that benefit has rolled out a little bit more. And in designing out this survey, which again, we are anticipating fielding in 2026 and 2027, we are really hoping to get input from HRSN beneficiaries on the survey itself before it goes out into the field. So next slide. So this is the timeline for everything we're trying to do before the survey launches in 2026. The big thing I want to focus on is the member testing of 2 HRSN surveys, which is in the bottom left corner. Really what member testing is here is asking someone who has received either a home modification or a housing HRSN benefit to read through the survey that we have designed and talk to us about, do the questions make sense? Is the wording for them right? How are you interpreting it? What is challenging and what is easy about responding to these questions so that we can make sure that we're asking the right questions in the right way to be able to really get information, to get the information that we're looking for when we send this out to several thousand HRSN beneficiaries in 2026 and 2027. We know that we're asking people to give us their time and their expertise. And so we want to make sure that we're asking questions in the way that's really going to value what they're giving us and provide us with the information that we need to be able to understand more about the impacts of the benefit. Next slide. So we have been, we've reached out to a couple of different CCOs and HRSN providers to try to essentially recruit people to do this survey testing for us. And we wanted to bring it to this space as well. I know that you will have access to the slides, so all of this information should be there, including on the next slide, which we'll get to in a moment, who to contact. But essentially what we're asking is, if you're an HRSN beneficiary or an HRSN provider who is working with HRSN beneficiaries who might be interested in supporting us with this type of survey testing, to please reach out to the email that you'll see on the next slide. And we can see if it works to be able to get your support on this. So yeah, next slide. So there, here's the email address that who you can reach out to if you are interested, or if you know folks who are interested in participating in this. Next slide. Oh, and the email is also in the chat. Thank you, Maggie. We have flyers. That was the the two slides were essentially slides showing what our flyers look like. So if you are interested in spreading the word, you can email Maggie. She can send along flyers to you. And then again, the same email address if you know someone who's interested and eligible to participate in this member survey testing. Next slide. Any questions?
In an effort to keep us on time, since we have many members of the public who are hoping to speak today, I am going to we have just a few minutes. Any questions? Otherwise, I think we will move along and have questions be submitted in writing to your team. Our list of public testimony is longer than ever today, which is awesome. And we want to hear from everybody. So
absolutely, we are happy to answer any questions via email. So please move along as needed.
For Hannah right now. Thank you so much for being here and for this update on the survey. And so Ellen or Penny or Sarah Dobra, are you here from the Ombuds group? Awesome, thank you.
Yes, thanks for having us. Really appreciate it. I'm Sarah Dobra. I use she, her, ea pronouns. I manage our OHA Ombuds program. And we present quarterly to MAC as part of our statutory enabling authority that asks us to present to the Oregon Health Policy Board, which we also do on an annual basis. And the Oregon Health Policy Board and MAC have asked us to present to you quarterly. You can go to the next slide. We will be brief today. Much of what we do want to touch in ties into the previous conversations as well, but we do want to just very briefly review like why we present to you. We will show some of our 2025 OMSPEDS data and emerging concerns. And as always, welcome questions along the way, which with we can answer then, we will, or we might just say, you know, we'll answer that later in the presentation, but always welcome discussion during and after our presentations with each of you. You can go to the next slide. And this actual skip, but is we just, you know, calling out our enabling legislation and why we do this work. Same, once you can skip the next slide, I will get into. You can go to the next slide, please. I will put a link to our website and all formal reports into chat so that you can always review those. We are always happy to go back and chat with anyone about any specific recommendations, and we'll touch on that a little bit today. We can go on to the next slide and why we do this work and how we do this as OMSPEDS work. Our OMSPEDS team each and every day talks to Oregon Health Plan members. We talk to them generally when services and programs have not worked as intended, when a member has experienced barriers to accessing care or the quality of the care on the Oregon Health Plan. And why this is so essential is that individual hearing from Oregon Health Plan members as they experience our services is absolutely essential, an essential part, a critical part of healthcare transformation. And so as OHA really focuses on and is committed to eliminating health inequities and co-creation with community, where we hear directly from our Oregon Health Plan members and those experiences is transformative. And the our team of OMSPEDS that I am so dedicated, you know, privileged to work with, hear from members each and every day. And that's some of what we share with you as we come to you. We can go to the next slide. And I will pass over to Ellen Penny, our principal OMSPEDS, to introduce herself and take it us through some more content.
Yes, thank you, Sarah. My name is Ellen Penny. I'm Principal Ombuds for the Oregon Health Authority. I use she, her pronouns. We are excited to start this new year with MAC and our charter that MAC was a co-signer on. And the way we have laid out our work with MAC over the year is presented in this slide here. Today, we were intending to present on the 2025 first quarter ombuds case data, which we will be doing. Review the status of past ombuds recommendations, and really call MAC's attention to those where we need, where MAC work and attention might be helpful. At the end of 2026 and biannually thereafter, it is our job, according to our charter, to review our charter with MAC and amend our charter, that's the Ombuds Program charter, as need be. I want to say here that we had half an hour for this presentation, but because of what is happening with HRSN and the numbers of people who can provide MAC with insights about how they are experiencing this program, and the fact that our first quarter data is full of these cases, we asked MAC staff to reduce our time to 15 minutes. We're therefore going to run through a part of our presentation that we would like to come back to MAC and spend more time on in June. But the trend that we need to highlight, the concern that we have to highlight for MAC, according to our own obligations, is really HRSN. And nobody's going to be able to share better information with you about that than the clients and their advocates who are coming next. Next slide, please.
Thanks, Ellen. And absolutely want to, reaffirm that directly hearing from those experienced in our services is what is transformative. And so just a step back before we go to more of that is that's perfect. The slide is perfect. Over the past several years in our reports, the OMSAS program has made 54 specific recommendations, formal recommendations, in addition to daily relationships with colleagues throughout the Oregon Health Authority and with coordinating care organizations, particularly our Medicaid partners in the Oregon Health Authority. And from those, there are some really notable successes. We will put in the MAC meeting materials is a spreadsheet of those recommendations and areas particularly of success. And some key areas we've really seen is just significant clarification, technical support, work on what does care coordination mean, and then also supporting enrollment and transitions, not only with the public health emergency unwinding that was presented to you earlier, but timeliness of supporting OHP members who move from one area to the state to another to enroll into their new CCO in a timely way, and some significant gaps in care. And there's several other areas, particularly home and community-based services for the basis of mental health disability is the area we continue to see both significant work by the Oregon Health Authority on, and then also needs to further improve. But just want to call out this transformative centering of member voice and the commitment of our Medicaid division to do that in partnership. And then also I want to really thank Amanda Braxton, who manages those ombuds recommendations through Medicaid, to think through that and highlight this process that centers members for transformative change. And with that, I'll pass it back over to Ellen.
And can we go to the next slide, please? So these are the slides we would like to come back to you all with in June, because we really want MAC to focus on the last slide. It is our obligation, not the last slide, on the trends for the first quarter of 2025. I think what we have to share with MAC today related to our past recommendations and where we could use MAC support is really important conversation to have with MAC. But I have to say, colleagues, that there's nothing more important right now than getting this HRSN benefit right. And you have such an amazing opportunity to hear from people who live and breathe it every day. So I am going to go to one slide, if you could just roll back down. Sarah's going to go to it. Slide number 12 is what
one more down.
Yeah, which is just an example of a change we're making in one of our recommendations. One more down. Keep going down. There it is.
Perfect. Oh,
Back
one up.
Yeah. And Sarah's going to
Thanks.
highlight that one, and then I'm going to create space for.
Yeah. Thanks. This is something we look forward to having more conversations with you about for all of our, not all of our 54 recommendations, but where it makes sense. Several of those 54 recommendations we had made in multiple reports over multiple years. And as we learn, hear from members, talk to our coordinating care organizations of what's working there, where are the gaps, hear from community. We really recognize our recommendations are point in time recommendations that should be solution focused and really based on the overall need. So we continually see and do see in the Ombudsman's program that we as a state have a lack of available mental health and substance use disorder treatment providers at all levels of care and for adults and children. The technical fixes, depending if you're a child or adult, in an inpatient facility or outpatient facility, are varied and technical. And we've spoken to those in our reports, but really wanted to make a very new, little bit broader recommendation that is very relevant to regardless of if CCO procurement moves forward in this time period or is extended later. But really critical area we do want to bring to Mac's attention to think about where we've talked about limited and closed networks by CCOs. We've sort of said that shouldn't occur, but we are proposing and making it change our recommendation to that CCOs cannot close their panels to new mental health or substance use disorder providers at any level that they cover services for. If the CCO has a wait list for clients needing mental health services or substance use disorder services, or if the first appointment for a new client is more than 30 days out. So looking at a little bit different technical and operation solution that I think should be talked about and thoroughly analyzed and implemented if possible. Again, we don't want to talk about this today, but would welcome coming back to talk more about this later, but wanted to give you food for thought too of innovative ways that MAP can also lean in and really one of our greatest statewide needs of access within mental health. With that, I'll turn this back over to Ellen for our quarterly data.
And you have the data on the slides, colleagues, but I just want to say because of the trend we are seeing, we pull data that will keep us up to date as of yesterday. So I don't need the slides anymore. I want to say we want to highlight HRSN for you. I pulled data yesterday since January 1st, 732 total Medicaid cases. You can take the slides down because they're not really relevant to this part of our presentation. 732 total cases since January, 688 were Medicaid. Of those, 145 are HRSN cases. 56 of those HRSN cases came in April. Most of our April cases involve eviction potential. And our cases, as you know, are just the tip of the proverbial iceberg. Before I go on, I want to step back and say I was thrilled, like all of us were, that Oregon was given the opportunity to use Medicaid resources for housing stabilization. It is a well-intended program. Housing is part of health. Housing support for people in transition can make a huge difference. All of us want this program to work. But in the Tri-County area specifically, it is turning into a nightmare for a number of people we have not yet found a way to quantify. These are the worst cases I've worked in my time here. People holding HRSN approval letters saying 6 months of rent and utilities are covered, are being evicted because providers, payers are not able to be found because the paperwork that they have submitted and was received and allows them to be determined eligible has been lost over and over again. People who are coming back from crisis, people in domestic violence, people who are coming out of rehab, people who qualify for this program as a result of their disabilities and challenges are being walked out of the doors of homes they have lived in some cases for many years, with only what they can carry on their backs, with 4 to 6 months of rent past due owed, hanging over their head as debt in the future. And maybe if the CCO can find them, they're being offered a week to pay for some kind of transitional housing. They walk out the door with debt, they walk out the door with an eviction notice, and their next step is to try to find a new home. They don't qualify for HRSN anymore because they're no longer housed. You're going to hear some of these stories. I think to add kind of insult to injury, when I'm holding that letter and I'm getting ready to pay for my 5th or 6th months, I can't pay that to my landlord because the landlord wants that past due money. We shared with Medicaid leadership in the beginning of April when we got our first case and connected with Shelley Latini, one of the most amazing advocates I've had the privilege of working with here, that we were seeing the beginning of the eviction curve. And I'm afraid I'm right. In my opinion, dear MAC members, there is a way out. There is a way to right this wrong, to protect others from being evicted who are holding those letters, to support much more prompt processing of applications. But it will require courageous, immediate, and creative effort, including all hands on deck action plan that includes our own agency. And sadly, I think that that plan needs to include a presence in the Tri-County area eviction courts. I heard you say earlier, Mac, that you were going to create a subcommittee to look at these legacy questions. I really encourage Mac to think about a subcommittee and a space to help be part of the solution for resolving these cases. I'm happy to answer questions. I do know that there are many others whose insights will be helpful for your consideration.
Thank you very much for your words. I can hear the sentiment and power in your voice. Are there questions or comments by MAC members before we move to public testimony? Lisa?
Yeah, I just have a quick question. So I know that the flex funds have been sort of gone by the wayside since the HRSN or HSRN funds have come into play in a bigger way. I don't know where oversight of the flex fund situation stands now because a lot of CCOs just stopped handing those out when the other funds came down the pike.
Is that a question, Lisa?
It's sort of a question. It's is there anything going on with flex funds since HSRN is a bigger pot of money now?
I can tell you the Ombuds experience with flex funds is that, of course, they're flex. There's no obligation for CCOs to pay them out for specific purposes, to process flex fund applications within any amount of time. Some CCOs paused on flex funds because they wanted to focus on HRSN. I think they were right because honestly, HRSN is huge. But Lisa, your questions are well asked. And I think the Providence team who spoke earlier would probably be a good place to suggest questions for the survey they're pulling together. My thought. Thank you.
Any other MAC member questions or comments before we move to public testimony? Okay, thank you very much for presenting today and for yielding and sharing and recommending that we shorten your presentation's time today to allow for more members of the public to speak. So the Medicaid Advisory Committee welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning, Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not a representation of the Medicaid Advisory Committee, its members, the Oregon Health Authority, or Oregon Department of Human Services. Each presenter is given 2 minutes to share. In the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate the next steps with each public commenter. We have written public testimony from Dr. John Santa, which you can review on our website. I've discussed with both my co-chair Heather Jeffress as well as our staffers Heather Weatherson, due to the large volume of interest in public testimony today, we are going to mute at 2 minutes so that we can move on and so that everyone is able to speak today. So we will, so Tom will be running a 2-minute timer that is on the screen, and then we will be muting at 2 minutes. And I apologize for that. It is in an effort so that we can hear from everyone. If there is additional information that you'd like to share, please do submit written testimony and we will read that. So we will get started. Robert Snoddy is first on our list. Are you here, Robert?
Yes, I am here. Good morning, MAC members and guests. My name is Robert Snoddy. I was the Internal Audit and Compliance Manager for Care Oregon for over 17 years. I will be presenting a summary of a letter sent to Governor Kotek and OHA Director Hathi regarding concerns of financial stewardship of taxpayer funds by Care Oregon. Budget deficits are causing public services to struggle to make ends meet. However, Care Oregon has more than $1 billion of taxpayer funds in a savings and temporary cash investment account. For what reason are these funds not being used to support services such as public schools, police department, and fire departments? How does retention of these funds improve public health? A possible way for these funds to be spent in a useful way is creation of an OAR, which requires CCOs on an annual basis to reconcile money that exceeds the CCO's restricted reserve account. These recovered funds can then be added to the Oregon General Fund. During my tenure at Care Oregon, and specifically within the past 10 years, colleagues and myself noted a pattern of hypocrisy where Care Oregon's actions conflict with the stated values of being good stewards of federal and taxpayer money. This is evidenced by Care Oregon's excessive number of management positions relative to other commercial and non-commercial health insurance plans. Care Oregon has 7 chief officers, 4 senior vice presidents, 10 plus medical directors, 52 vice presidents, and 85 plus directors for a staff of 1,500 employees with 840 position descriptions. This compares to 2015 when Care Oregon's leadership consisted of 4 chief officers, 2 executive directors, and 9 other directors. Also, internal controls to mitigate risk and safeguard taxpayer funds are lacking. I also want to point out the duplication in services between Care Oregon and Health Share of Oregon CCO, which also has a senior management personnel and administrative staff. The Care Oregon Health Share relationship is so convoluted, it doesn't make sense to operate these two as separate entities. In November 12, the objective of OHA was to ensure that eligible Medicaid members were assigned to a CCO. In March 2025, 7% of the Medicaid population was an open card, which makes us the 3rd largest CCO. It's my hope that thank you.
Thank you for your testimony. Leslie Nelson.
Hi, thank you for letting me present today. My name is Leslie Nelson. I use she, her pronouns. I work with the Community Law Division of the Metropolitan Public Defender's Office. In that role, I manage a team of housing attorneys. Our attorneys are in court every day representing people who are being evicted, in addition to doing other housing work. But we are regularly now seeing people who have been approved for HRSN money and they have their letter in hand, but they aren't getting the funds in time and they're having to lose their housing. They're having to come up with agreements to move out of housing because they haven't been able to receive those funds. These cases move pretty quickly. A lot of people end up in court, landlord-tenant court, without attorneys. Most people, in fact, end up in court without attorneys and are having to navigate this process without any help. I want to give one example from a case I had last week, and this client has allowed me to tell her story. This is a 59-year-old woman with Parkinson's. She applied for the HRSN money in November. In January, she had her letter saying she was approved. We had the first appearance with court.
Leslie, you've frozen.
Oh, shoot.
Looks like you're back with us.
Sorry.
You paused at first appearance in court.
Sorry about that. We ended up at first appearance. She had her letter in hand. We were assured that she would get the funds in time for the trial date. So we set the case out for trial, which was set for last week. At that time, she did not have the money. It was not forthcoming, and we had to work out instead a move-out plan. The landlord was nice enough to give her two weeks to move out, so she has to be out by May 5th. This is one example. We see this all the time. We've been seeing this lately all the time with our clients, and it's very frustrating. We don't know how to help them. We had another person that same day with the same issue without an attorney. Thank you.
Thank you for your testimony. Anita Einger, apologize if I've mispronounced. Are you
No,
here?
that was perfect. Good morning, everyone, and thank you for this opportunity to provide public comment today. My name is Anita Iyengar. I serve as Legacy Health's Chief Strategy Officer, a Pacific Source board member, and I also happen to be a member of Pacific Source Health Plans. I wanted to share some insights about what went into the Pacific Source transfer decision. Our top priority is to provide a seamless experience for Pacific Source members with no disruption and ensure continuity of access, service, and healthcare for them. Pacific Source members include some of the most vulnerable Medicaid populations in our communities, and they rely on their Pacific Source plans to afford life-saving and life-changing Medicare. We are grateful that Oregon has a great CCO structure that prioritizes care for patients on Medicaid. That work we think is incredibly important, and we are proud to support it. We are confident that transferring Pacific Source to the foundation is the right path forward for several reasons. First, this transfer maintains continuity of governance and stewardship. The foundation's fiduciary board will be made up of people who are intimately familiar with Pacific Source. Second, the foundation is aligned with and will support Pacific Source's existing missions to improve the health of underserved communities in Oregon. Third, it prevents a rushed sales process that could compromise the long-term stability of Pacific Source. And finally, it preserves Pacific Source's stability and will not have a material impact on its finances and operations. The foundation, which will be well capitalized through Legacy's net cash at closing, does not intend to seek any dividends or distributions from Pacific Source. I also want to note that Legacy Health and OHSU intend no changes to Pacific Source and HealthShare's current IDS contract. All parties involved share the same goals of ensuring HealthShare's members maintain excellent access
Thank
to
you for
community
your
providers.
testimony.
Okay.
Thank you. Carmenia?
Yes, hi. I want to say that I have been through domestic violence. I am a foster child that was aged out, and I went through domestic violence. I've been through child incest, abusive relationships, and homelessness. And I'm in recovery. When I finally got housing and got off the streets, I was so happy that that program, the HRSN, was out there to help me, because I had been through so many holes of not getting help. And because I have Kaiser, my mental health is Care Oregon, so I applied for the flex funds. I couldn't get it. I applied 3 times. And then someone called me from HRSN and said, "Hey, we know about what's going on. Apply." I applied the day it opened and got approved November. I still don't have the money for my rent. Luckily, I have an understanding landlord. I have not heard anything about the statistics of people who actually don't have their rent paid. I haven't heard about when they're going to get their money or what's going on. All I know is everyone that I talk to has people that are becoming homeless. I don't want to end up, I'm disabled and I have cancer, and I'm going to be out on the streets if I don't get my money, to help me. And I don't understand it. Why isn't there more statistics about the people that don't have the money, and why aren't people moving towards trying to help them? If that makes sense.
Thank you for your testimony. Shelley Latini.
I'm Shelley. I'm the community partner and advocate, domestic violence survivor, and former foster youth. I'm going to move fast. From the start of the program was set up to fail. It lacked adequate staffing and resources to meet the needs of Oregonians. By week 3, 211 reports over 7,000 applications in arrears. It's impossible to process applications promptly without proper funding and staffing, but they were still guided to launch anyways. Now we're seeing the fallout from a program that rushed and under-resourced during the rollout. There's also never been a consistent workflow for submitting necessary documents. No case numbers, no IDs, just chaotic floods of emails with no ways to match documents to clients. I call it email jail. Advocates, landlords, and attorneys send documents repeatedly, often with no acknowledgement. It's chaos. Just yesterday, I sent the same lease for a member that I've sent 6 times since February. Even after submitting the documents in the final review process, the Care Oregon receives documents in pieces. Again, that hamster wheel starts over again, recollecting the file data. And once approved, yet another delay. Applications are waitlisted for a payer procurement. Why is assigning a payer so difficult? Why isn't Care Oregon or HealthShare stepping in? If the funding was received a year ago, why are people still being evicted? Why, even after payers are assigned, are rents being paid late, utilities being shut off? Why is it so hard to access this funding? Clients and advocates alike sit 3 to 5 hours on hold just to hear we have no updates. We're doing the best we can, and your case has been escalated. Court cases are piling up. Weeks and months pass without a payer, without funding, despite countless calls and rescheduled hearings. There's no support from Care Oregon, no housing mediation with landlords, no legal aid, no navigation, no intervention when housing is at risk. After applying, clients are met with silence. There's no word strong enough to express what they're going through. These are our most vulnerable Oregonians in crisis. They're not getting answers. My clients might only have 2 minutes to tell you today their story, but I assure you there's thousands of them like that out there. I've spent over 1,200 hours on this, thousands of phone calls, no resolution. I just hope you understand the severity of this crisis.
Thank you for your testimony. Kendra Middleton.
My name is Kendra Middleton. I lived in my apartment for over 15 years. I was scared and frustrated. I've been a freelance accountant. I went through a medical crisis. I applied for HRSN in December. I met Shelley at my first court date. And she has tried to help advocate for me. I had a second court date where I was told I was approved the week before, but we still didn't have the letter. Nothing to show the attorneys. I had to settle for a move out date, so I didn't get an eviction on my record, and I moved out the end of February. because the promissory note wasn't delivered in time. I was displaced and houseless for over 8 weeks. The first motel I stayed at was off Powell Boulevard, which was drug infested. I was forced to leave my community in Lake Oswego. I've received zero advocacy and support from Care Oregon or HealthShare. My anxiety is really heightened and my mental health has been destroyed. I'm now left with over $20,000 in property debt. I finally did get myself rehoused a week ago in downtown Portland. Only thing Care Oregon helped me with were the moving costs. They did do one motel stay when I was trying to get into another apartment, but that failed. And I still have things in storage. I can't afford to pay. I'm still struggling to pay rent, my storage. I'm not stabilized in housing. My car was also totaled a couple weeks ago. And while I was living in a motel, so I've not received housing support and I could possibly face eviction again due to still not having a job and being able to pay rent. So that's it. Thank you for your time.
Thank you for your testimony. Molly?
Hi, my name is Molly. I'm a former Care Oregon HRSN employee. I ended up leaving work because of panic attacks and anxiety, and I am now a client. I've been waiting months to get housing benefits since I applied in January. I've been approved since February and am now at risk of eviction. And I'm running out of resources. My advocate and I have spent countless hours on the phone to no avail, and now I'm having to borrow money as May rent is approaching and I've depleted all of my resources. This is having a huge effect on my mental health since it's very hard feeling this instability. I am disabled and this is just feeling very difficult to navigate. Thank you for your time.
Thank you for your testimony. Emily Jarvis?
Emily's here with me. This is Shelly. She's just going to testify from my computer and she wants the camera off.
Hi, my name is Emily Jarvis. I am 27 years old. I had went through a mental health crisis last year, which resulted in hospitalization. I applied for the HRSN Housing Stabilization Program way back in December. I got approved in February, and I am now facing eviction because I am still in payer procurement. There's been hours wasted on the phone just to hear there are no payers or that my case has been escalated. I've gotten late notice after late notice. There's been no support between myself and my landlord. I'm scared if I don't get this help soon, I'll be evicted on the streets next month while still trying to recover from mental health crisis. I'm currently in therapy. I'm back to work at my job. I've been there over 3 years. In my apartment, it will be 3 years next month. I have no backup plan. This is causing me a lot of stress and anxiety. Thank you for your time.
Thank you for your testimony. Chelsea Mercero?
Yes, I'm here. My name is Chelsea Mercero. I'm a single mother of 3 children with special needs. I have several different disabilities, which caused me to apply for the HSRN Housing Stabilization Benefit in February. And at that time, I had an eviction pending for March and had not heard anything from HSRN program after hours and hours of waiting on hold, trying to get updates to no avail. I finally got a voicemail on April 6th from a call center that asked me if I received housing services, but nothing after that. I filed an ombudsman complaint on April 16th, and I did finally hear back from the ombudsman on April 23rd. My children and I are now houseless as of April 11th after a 9-year tenancy. I have one of my 3 children with me, and one has since been estranged due to this situation. We're living in the basement of a church in Milwaukee, and we're waiting to move into a motel and enrolling in a program that provides housing case management to get rehoused, hopefully. I never received any advocacy from HSRN. I never received any housing stabilization. I never received any utility support. And in fact, from months from when I applied and when we lost our home, I never even received a phone call. It's now been over 60 days since I applied. I also lost my job shortly after losing my housing due to all the stress of this has caused. So now I'm unemployed, estranged from one of my children, sleeping in the basement of a church, and my kids and I are in a complete mental and emotional wreck. Thank you for your time.
Thank you for your testimony. Jermaine Oliver. Jermaine, are you here? Okay, we'll move on and circle back at the end. Bobby Joe?
I'm here.
Oh, Jermaine, you're here? Great.
Yes. My name is Jermaine. I was in a serious car accident last year. I applied for HRSN in December, and somehow my application went missing after lots of follow-ups. I worked with my advocate, Shelly, and reapplied in February. I've been sitting idle ever since. I have an 11-year-old daughter. I just finished physical therapy. I'm back to work part-time doing construction. I'm severely behind in my rent. I've lived in my house a little over 3 years now, and I've had several trial extensions. I've waited hours and hours on hold. I've gotten no support from Care Oregon, and all I hear is that I've been escalated and somebody will get back to me. My advocate and I spent hours and hours upon hours, on the phone and sending documents over and over again, wasting time and causing frustration between both of us. If something doesn't change, I'm gonna be homeless with my 11-year-old daughter and still basically recovering from my car accident. My water is currently shut off at this time due to lack of resources and income. Thank you guys for your time.
Thank you for your testimony. Bobby Joe? Bobby Joe, are you here today? Okay, we'll circle back at the end. Desiree Catalano?
Hi, I don't have anything prepared. I just in the meeting today, and I just want to echo everything that different members have been sharing, the same things that I've been trying to support clients through. I'm a social worker. I work for a small case management agency, and we serve primarily medically homebound folks. And we're working through multiple situations right now where there's a trial court, there's eviction court. People have had letters for approval since January. And now they're reaching the end of the period that they were supposed to be approved for parental assistance now that June is coming up. And so even if they get back pay or if they're not evicted by that point, we're looking at June with the same issue going on. Of course, there's sustainability issues with that as well, but every client that I have seen get approved for this has still not gotten funded yet. And the nightmare of paperwork, I dedicate at least 2 days of my work week to calling Care Oregon because hold times generally go from 8 a.m. to maybe sometimes 1 p.m., sometimes 2 p.m. Sometimes I get cut off and somebody answers the phone and they say, we can't help you because we're working on the backlog. I get it. Everyone I've talked to at Care Oregon has been super supportive, amazing, and nice and helpful, but it is such a mess. And so many clients have just thought that they're like, oh my God, all right, I got the letter, I'm approved, this is okay now. And then they still end up evicted, just like many people have already shared. So I'm just hoping to connect and figure out ways to streamline this process, help clients, help coworkers, help people apply for this in the best way possible, and to follow up and track these things in a meaningful way so people aren't kicked out of their homes. Thank you.
Thank you for your testimony. Bobby Joe, are you here? Are there any other members of the public here today that are hoping to testify or give testimony? I apologize. Well, I want to thank everyone for taking the time and the vulnerability to share today, and to take a moment to acknowledge the really powerful stories that everyone has shared. So thank you all. we will move on to the final portion of our MAC meeting, which is the MAC discussion. So I have a few different announcements. So we are looking for volunteers to help with the Legacy Health Foundation Pacific Source transaction Form A discussion. So as I mentioned earlier, if you know you would like to be a part of that subcommittee, please message Sarah. Otherwise, Sarah will also send a follow-up message to MAC members after this meeting to look for volunteers. I also, before I forget, and Ellen had from the Ombudsman group had requested that we consider forming a subcommittee regarding the HRSN eviction situation that we just heard so much about. Are there thoughts about that from MAC members?
I agree with Ellen. I think we need a subcommittee.
I myself also agree. Are there other thoughts?
I
Thoughts
would
on this
say
HRSN benefit, or what is it you're saying? I'm sorry.
A subcommittee evaluating the HRSN benefit as in respect to the evictions that are happening in the Tri-County area.
I mean, I'm not from up there, but I do help run HRSN down here in Klamath for CHA. And hearing their testimony, I'm like, there is some big disconnect happening because that's not happening with our members. And if it does happen with our members, like we have the letter, we know the eviction laws, like we know all of these things. And I say we, as in my team, the SCOH coordinators on health equity. So I think that, I mean, I don't know if I could benefit because I'm in rural Oregon, but I think a committee would definitely assist those members because for all the things that they had just said, there is some huge disconnect happening. Or maybe as simple as things aren't getting explained to them in the most basic upfront way. You know, like when we talk about HRSN down here, when I'm approving or denying services, I go through the auth and then I'm in constant communication with that member, and the member has to do footwork as well, big time, and stay in communication with their landlord. So there's just a lot of steps that I think would help these individuals. And if it's a subcommittee, then I say yes.
This is Heather, co-chair. I do think a subcommittee to address these really serious concerns, and particularly as reported here, both by committee members and testimony, that there's wide variance across the state. As a MAC member, that's concerning to me that these concerns have not been captured through a natural quality improvement and continuous improvement process to this point. So really appreciate the Ombudsman bringing this to our attention through their report. So I think that definitely needs to be part of the discussion, is how can the MAC support resolving the situation and creating a way to capture this information more consistently and earlier. That would be of top of mind for me in any subcommittee work. But
yeah, capture and then help streamline it, because it seems like there's just communication. Like we tell them on the front end, this is not a fast process. It has to go from us to the auth to the finance. Like there's so many factors to it.
Would someone like to make a motion to form a subcommittee to investigate this further?
This is Lisa. I'll make that motion, please.
Do we have a second?
I'll second.
Any objections?
Nope.
Any abstentions? So similarly, if you would like to be a part of this subcommittee, please message Sarah. Otherwise, Sarah will also include a request for volunteers in her follow-up email. In talking about moving on and talking about our upcoming MAC retreat on, I believe it's May 28th, next month, there is a request to extend the meeting by 30 minutes given the amount of topics that need to be addressed, specifically about the discussing bylaws, charter, Form A recommendation, to discuss those things prior to our June meeting. And if unable to extend the May meeting, a request for a short special meeting in early June to have a additional discussion prior to the June meeting. Other policy committees and boards from OHA do intermittently have additional meetings when there is too much to fit into a typical agenda time. What are people, we were discussing either starting early at 8:30 or continuing until 2:30. Is that possible for people, or do people prefer to have an additional meeting? I don't know that we need to make a specific firm decision today, but to bring that up.
I vote for an extension at the end of the day, not earlier.
I agree. This is Jerry. I agree.
Is it problematic for anyone to have an extension at the end of the day until 2:30? I'm not hearing any objections, so I think we can move forward with an extension at the end of the day until 2:30. We also, on that note, if at all possible for MAC members to join us in person in Salem for that meeting for some in-person energy exchange and communication would be fantastic. I know I am a big fan of being able to meet virtually so that we can all be across the state with our various lives, but if able to meet in person, that would be fantastic. There would be providing breakfast and lunch. Reimbursement can be provided to those who are eligible for travel. You can contact Sarah and Tom about details for that. And then finally, I don't know that we have time to fully discuss this today, but we have been in the last number of months been asked to make recommendations, and again today about the Form A, and wondering about, should we as a MAC come up with some sort of rubric that we follow for when we are making recommendations? This is partially coming up in response to the request for recommendations from, I believe it was a presentation at the February meeting that I missed, and then a request for recommendations today, and then a potential changes in federal Medicaid funding in the fall, and if we are going to have changes in Medicaid eligibility and potentially be asked to make recommendations. Should we have a general rubric that we follow when we are making recommendations to OHA? For example, should we have criteria such as, are these recommendations evidence-based? Do they harm members? Is there an equity lens? And some various thoughts about, should we have a standard rubric when we are making recommendations? Are there any initial thoughts to that idea?
I think that sounds like a great idea. I think the changes could be vast, and we need to consider all the factors impacting not only just the individual services, but where people might get those services if the cuts are as devastating as they currently sound like they might be.
In terms of, I feel like we're talking a lot about subcommittees today. If we're talking about the creation of a rubric, in what setting do you think would be the best way to come up with a rubric? Do we need yet another subcommittee? At this point is brainstorming here, so open to any thoughts from any member of the MAC right now. just trying to, I think the goal, the purpose of this is trying to have some level of consistency of when we are requested for a recommendation from the MAC to OHSA that we are, I'm sorry, OHA, that we are making recommendations from a consistent lens, and that we are prepared, and that we're not responding to things by our gut, and that we have a measured response to very important issues.
Caroline,
Mhm.
this Heather, sorry. Is it okay?
Yes, please.
I think that's good. I'm not ready to perhaps we should talk about this more at the MAC retreat and then
Agreed.
determine that we make a final decision on a subcommittee, because it may be that we can cover enough rubric items based on our work plans and the development of our new work plan that perhaps staff could do some background work from gathering that information from our public meetings and our retreats, and then maybe be able to share that with us and have the larger group vote on it. So I would say in the hope of efficiency, because we've already approved two other subgroups, that maybe if we maybe leave a little space for us to ponder if we need another subgroup or if there's another way to address this in a meaningful way for the committee.
I think that sounds fantastic. Sarah, does that sound like a reasonable suggestion?
Yeah, I think that's great.
Awesome. Okay, thank you. I appreciate you all considering that. Are there any other any other items for discussion from the MAP? Those were all of my announcements / items for discussion. Okay, so now I would like to turn the meeting over to Sarah Weatherson to close us out.
Great, thanks a lot. It's I just personally want to thank everybody who testified today. I heard a lot of people being very very vulnerable and speaking to us about things that are very difficult. And I appreciate that you were here and sharing that information with us. And in the spirit of continuous improvement, we like to close our meetings by asking for some roses, the things that you enjoyed about the meeting, some thorns, things that felt a little pokey today. And we also like to check in with our members about buds, things in the meeting that you'd like to nurture in the future. And so if MEC members want to weigh in.
This is Lisa. It was great to hear from so many members of the public today. We usually don't have that many people testifying.
This is Heather. Same ditto on Lisa. It was really an honor and a privilege to see public testimony used so robustly today to bring forward concerns. That's what public testimony is for, and I totally honor and respect it. Can be daunting and challenging, but public testimony is a formal record where things can be heard in a very different and important way. So just a huge respect and thank you to everyone who came today to do public testimony. Thank you so much.
Okay. If there aren't additional comments from MAC members, we've still got a minute. Yeah, Ellen, our honorary MAC member. Ellen, my friend, you are on mute.
I just put my question in chat, but I know there's a lot of folks here who would love an answer. there are many folks who are interested in HRSN who have great ideas about problem solving. I heard one of them speak today. Thank you so much, Kaya, I think, and Desiree. I'm curious if these subcommittees allow for non-MAC members, how folks will find out about when that subcommittee is created. Those are my questions. So you can maybe say that for this group to understand how that subcommittee process works. Appreciate that Mac has done that, by the way.
Ellen, we're in a little bit of uncharted territory. We often have subcommittees that tackle something like our bylaws where it's really clear what the ask is and where we're going to go with that. This is a little less clear, and I think is going to take more than 1 or 2 meetings for us to dig into. So I don't have a simple answer for that. That said, we will start the process of creating a subcommittee to dig into this, and I imagine we can um, get that out through our listserv to folks, follow up in our next meeting about it, that kind of thing. If folks aren't already on our listserv, I invite you, and I'll drop the Mac info email in our chat to get in touch with us. We can give you information. I think it's something you have to do. I don't think we can put you on the listserv, but I don't have that information handy, so that I'm sorry, I'm going to make it a 2-step process. But yeah, we can continue to follow up with folks as they would like to be followed up with. I see that Jerry's hand is up.
Yeah, just one slight maybe variation. If we can't have non-MAC members participate, could a MAC member bring an expert from their organization that deals with HRSN with us to that subcommittee? It would probably provide a lot more clarity on how to streamline things and what's happening from the perspective of those of us who are trying to process this paperwork and getting it rejected and losing it out there in Neverland. So just a thought.
Thanks. I will say, I think the decision about whether to have non-MAC members on a subcommittee is
Sarah,
under, yeah.
sorry to interrupt, but subcommittees can research the data that they need, and they can do that in a wide variety of ways. Is that correct?
Absolutely.
Thank you.
Sure. Which might, yeah.
Which could include bringing experts or written things or et cetera and so on. Research projects, examples, et cetera. Yeah.
Yeah. And it could also include holding listening sessions and that sort of thing. Okay. So we are at time, and I am we're gonna stay on for a sec so people can get this email address if they need it. I type in here right now, and oops, let's see.
Ellen, would you mind putting your contact information again in the chat in case anyone came on late from the last time you did it?
No worries there. And Carmenia, I want you to see that, and please reach out to our Ombuds program. And thank you so much for being here. I will put our number and information below again. Thank you. Let's see.